Oh, we are live on Facebook. Hi, Dr. Moore here. This is our third installment of Fibroid Awareness Month, and tonight we have a particular pleasure. Last week we had a patient who came in with called us with a conflict of interest, couldn't show up, but tonight we have Joan Pranaris. Joan and I met in 2004. Joan had fibroid. She'd been diagnosed a couple of years earlier and was searching for what was right for her. And so I'm going to kind of let Joan tell her story, and thank you for being here, Joan.
Thank you. So yes, as Dr. Moore mentioned, I had been diagnosed with fibroids a couple of years before seeing him. My symptoms got so bad, heavy bleeding was the main one, that I decided to go ahead and find a new doctor that was a specialist in fibroids, and I think I had heard about him. He was speaking at Porter Hospital, I think. Mm-hmm. He did a presentation about the options for fibroids and how, as far as surgical and non-surgical options, and so I decided to make an appointment and see him, and so we discussed the options available, and I was the least invasive. I didn't really want to do surgery, so I tried a bunch of different things. I think I tried the Mirena IUD. I tried taking, I think it was Prometrium, and different treatments to try and alleviate the bleeding. Mainly the heavy bleeding was what bothered me the most. None of them worked, so I then wasn't sure what to do, and so I tried all these other options, I think, over a period of a couple of years, a year or two, and but my symptoms got so bad. I would have, at the time I was going back to school, and I had accidents at the college. I remember going on job interviews and being absolutely terrified that I'd have like heavy bleeding come on all of a sudden. So it was very disruptive to my life, and it got so bad I couldn't even leave the grocery store. My bleeding was so heavy, and I was just going back and forth to the bathroom and checkout and bathroom, and so I'm like, I've got to do something, and I just was very. It was so disruptive to my life, so I decided to agree to get laparoscopic myomectomy, which is minimally invasive surgery, and my life totally changed after that. I mean, I got my life back, and I think it took maybe about a month or two. I mean, immediately I noticed the bleeding was greatly reduced, but it just got lighter and lighter as time went on. And I just had such a peace of mind, and I wished I had done the surgery earlier, but you try to find the least invasive treatment first, and then maybe go for surgery. But in retrospect, I felt I should have done it. I wished I had done it sooner, because I just would have had another year or two of a non-intrusive or less fear-based life. So and he was great. Dr. Moore was great, because I think he was going to take out like 3, and after the surgery he goes, well, I think I took out 9. I don't know the exact number. And I was thinking, wow, that was really nice that he didn't take out the key ones we were looking for, but he thought ahead of time. Yeah, thought ahead, like, well, these are going to cause problems in the future. So I felt that he really was good about thinking ahead and what might be bothering me in the future as well. So, but I got my life back. The bleeding was reduced by probably 75%. I didn't have fear of accidents anymore. I just, like I said, I wish I had done the surgery earlier. But it's a different choice for each woman. And I was really happy with the results and how everything went, and everything went very smoothly. And I thank this man for it.
So you were at the grocery store one day during your period,
yeah.
And you could not get out
Yeah.
of the grocery store.
Yeah,
right?
I was running in with the box of tampons that were in my basket for checkout, and going in the bathroom and changing, and then by the time I went back out to go to the checkout line, I had to go back into the bathroom.
Oh, poor
and
girl.
I think that was the straw that broke the camel's back. because I thought, this is no way to live, and I'm just miserable, and I've got to do something, and nothing else has worked. So,
You know, I've met other women who literally told me they couldn't leave their bathroom
yeah.
for a day or
Wow.
two, except just maybe to get some water, something to eat or
gosh,
something, because
yes.
they just simply had so
Yeah.
much heavy flow
Oh, yeah.
that they just couldn't go anywhere.
Right.
And so, yeah, that definitely gets your attention.
Yeah.
Now, before you saw me, I suspect you had discussed surgical options with the previous doctor. Was that?
I actually don't remember, but I remember the bleeding wasn't as bad then, and I had always been a heavy bleeder. So I just thought, well, you know, it's just going to be a little bit more, and so I just really didn't pay much attention. I mean, there were other minimal symptoms like, you know, pressure in the abdomen and some cramping, but I just thought, you know, as long as the bleeding was the main thing for me, and so it wasn't really bad until I moved here, and it just, you know, as time went on, it just got worse and worse. And then I saw you at that point.
Okay. And we talked about all the options. I mean, you were offered hysterectomy, myomectomy,
Right.
not, you know, just take the fibroids out instead of hysterectomy.
Right.
And so we talked about lots of, you know, options here. And then, you know, you helped decide what you felt was the right procedure for you.
Right, yeah, and we worked together as far as trying different options like the Marina IUD and what was the Prometrium, non-surgical options, and so I decided to take those first, and then you did recommend hysterectomy. So you basically told me all the options, what they were, and I felt that we had a good give and take, and you listened, and you went along with what the path I wanted to go down on that, and then, you know, until ultimately the laparoscopic myomectomy surgery. So, which I think you might have suggested was a good option. I probably should have listened to you first, but anyway, I felt that you respected my choice to kind of start from the the minimal treatment up to surgery. So.
Oh, thank you for that compliment.
Well,
That's
you.
the way I always try and think of my patients as my family,
Yeah,
as my friends, and what would I want. And so you had a pretty quick recovery. How many days do you think it was before you were driving?
I remember the recovery being very minimal. I remember being on my couch a few days, and then I think I was walking after that. I mean, I still could walk around, but I just, you know, had to take it carefully. I think the work, like working out or doing, you know, heavy lifting, I think it was a couple weeks. I'm trying to remember exactly, but I remember the recovery was very minimal, and I was actually surprised how minimal it was. I thought it was going to be out for 3-4 weeks, and it was, it was pretty quick actually. So.
And that's the way it is for most women. Is, you know, the first 3 or 4 days are a little kind of not so comfortable, and you're moving a little slow, but by the end of the week, 4 to 7 days, most women are able to drive again. And you know, I've got a lot of patients tell me they either log in or they went to their office and worked. I mean, half days generally.
Right.
But 10 to 14 days, the average patient's pretty much back to work full time, and unless it's a real strenuous physical job where you have to do a lot of heavy lifting. And you decided to allow me the honor of continuing your care, and then about 8 years later, we had kind of seen some fibroids starting to recur. Right. We kind of watched them, and then you started having the bleeding issues again and getting a little worse. But these fibroids weren't really the big ones, they were just the little ones. Right. And then we went in, instead of a laparoscopy with the abdominal incisions, the little incisions, we did the hysteroscopic myomectomy. Right. And that's where I used the scope to go through the cervix to remove those 2 little fibroids. And that recovery, what do you recall about that, Joan? Because
I don't recall much because I don't remember it being that interfering with my life. So I think I was okay after a day or two. And yeah, it was the one before that was a little bit longer, but I think I was back to normal in a day or two.
Yeah, isn't that great?
Yeah,
to be able to have a surgery for your fibroids where you're back in a day or two, and that's what we know is that when the fibroids are just starting to cause symptoms, sometimes we can do the most minimally invasive technologies. And that's where something that wasn't available when you came to see me, but is just now available and just now FDA approved, is called the Sonata procedure.
Oh, wow.
So instead of going to the hospital and again, it would not necessarily, without going back and carefully reviewing your file, you might have needed that laparoscopic surgery, but maybe had I seen you in 2002, we might have been able to do a similar procedure where we go through the cervix. And in this procedure, the Sonata procedure, you put an ultrasound probe directly inside the uterine cavity. Now you've had transvaginal ultrasounds, and they're not uncomfortable, and they allow us to see the pelvis and such. But to actually be able to put a probe inside the uterus is brand new technology. And when I first started in practice, I was using transabdominal ultrasound, and when I converted to transvaginal ultrasound in the mid to late 80s, I was amazed at how much I could see. And that revelation occurred again when I started doing the Sonata trial, because I'd done the transvaginal scan. I had seen, and I'm a pretty good sonographer, and there were more fibroids, and I went, wow. I mean, this is even better. And so what's really cool about the Sonata technology, Joan, is I could put a needle into that fibroid. So you might have not have even had to have had that laparoscopy the first time had I been able to use the Sonata technology then.
Wow.
So we could have put a needle in the fibroid. The needle has little extra needles that come out, and it creates a kind of sphere of tissue destruction, of what we call radio frequency ablation. I like to use the word zap, zapped it.
Right.
So, so we could get those small fibroids. And I'm pretty sure, I think you did have the submucosal fibroids that we took out in 2012. And I think you might have had one or two left over somewhere in the middle. They weren't real big, they weren't causing a problem, so we didn't need to do another laparoscopy. And we treated the ones that were growing into the cavity. But what I see in some cases, and I was very pleased that we were able to get all those fibroids in your case, and when our fellows reviewed those files and they looked at you and the other couple hundred women where Dr. Walliser did the fibroid presentation for the society meeting, 75% of the time we were able to get all the fibroids. But those ladies who had a lot, and then they had the little tiny ones kind of right in the middle of the wall of the uterus. So those were the ones that 25% of the time weren't able to get every single one of them. And the problem is they grow over time, and a woman's at risk for another surgery. And the problem with fibroids is they do reoccur. But with this Sonata technology, I could go in and do a laparoscopic myomectomy and take the big ones out so they're not sitting on your bladder anymore. And then I could zap the ones that are left behind right then and there.
Wow.
Or,
That's great.
when we did your hysteroscopic myomectomy and we took the ones out through the cervix, I could have, same thing, taken the needle, zapped the rest. And again, trying to prevent those from becoming a problem later.
Yeah, that's great.
So it's just an incredible advance. And we were talking about that 15 years ago. Wouldn't it be nice if we could do something like that? And now it's available, and we very quickly, the company is rolling out, and we should be able to get a unit here in Denver soon. And boy, I just see this as one of the best advances in the last 20 years. Since the morcellator became available, that's the instrument we use to take those fibroids and get them out, relatively quickly, so we could keep your incisions really teeny tiny.
Right.
Can you even see your incisions anymore?
No, I don't think so.
Yeah, because they're little teeny
I was
tiny
surprised
ones.
how small they were after the surgery, and it was just they didn't hurt or nothing. So I was like, did I even have surgery? Doesn't look like it. But yeah, so I think they were like an inch or something. So that was great.
Well, I'm glad, and thank you for being here and telling your story.
Thank you.
So now another thing that's happened is Fibroid awareness, one of the news channels locally has taken an interest, and tomorrow morning on Channel 9 at 7:15, they're going to allow me 3 minutes to share fibroid information with patients on TV. Now, at 7, Channel 9 switches over to NBC, so you get the national news. So what they do is they go to Channel 20, and so Channel 20 is where they continue to do local news features and things like that. So that's where I'll be at 7:15, and they sent me the questions ahead of time. So we're going to do the question answers now. So nobody has to be up that early if they don't have to be, because you get the answers to the questions now. And one of the things that they just want to know is what are fibroids. And the uterus is a big muscle, and inside's the cavity, and that's where the baby implants. And the baby's all happy and they're growing and everything's good until labor starts, and that's kind of like the eviction notice for the baby. Is then those contractions of that muscle start to make the baby deliver. And each muscle cell in the uterus has a potential sometimes to mutate into a fibroid tumor. And there are women who come in with 1 or 2 or 3, and then there's ladies who walk in the door with 30 or 40. Why they have that potential to have so many mutations is not clear, but each separate tumor has a separate, different genetic makeup. Now, they're almost always benign, like 99.9% of the time benign. And so we're kind of taught to treat them as benign until proven otherwise. So if they're small, there's not much symptoms, then we just kind of tend to watch them. Or if the bleeding's a bit of a nuisance but the fibroids aren't real big, then things like birth control pills or the Mirena IUD, those are things that can sometimes help, but the problem is eventually they continue to grow, and someday maybe we'll have a way to keep them from growing. That would be easy. The Sonata is, like, to me, the easiest thing I've ever seen. And if you can get them when they're small, you can keep them from growing to be big tumors. And I see that the future is we can eliminate a lot of laparoscopic surgeries.
Definitely.
Now, I can't remember if you've ever had an open abdominal surgery.
No,
I forgot all about that. So,
yeah.
so women who have had open abdominal surgery, the 2 most common phrases I hear from them are walk in the park and night and day. That the pain and recovery from their laparoscopy compared to their open abdominal surgery is like night and day. The recovery, the return to work and all that, it's a walk in the park compared to what they went through. Especially if they had an up and down incision. That's usually 8 weeks off work compared to the transverse incision, the C-section type incision, which is 6 weeks off work. And Dr. Grace Liu, who did our very first presentation, a fellow presentation, she was our very first fellow here. She was gone before you got here. I think Dr. Brown was the fellow who was here when you were seeing us as a patient. Tammy Brown, she's now back in California, which is her home. She came out and spent a year fellowship with us, and tried to teach her as much as we could. But Dr. Liu, she did the first 104 laparoscopic supracervical hysterectomies that we did, and she looked at the data, and the average patient said they were able to go back to work in 10 days and felt fully recovered in 3 weeks, and it was just amazing, the recovery from that. And if we can even avoid laparoscopy compared to open abdominal surgery, that's just incredible about how much more quickly women can return to work. Just like you observed with the hysteroscopic surgery, where no incisions were needed to do that procedure. I look at this as being a way to, you do it on a Friday, the woman's back to work on Monday, and instead of being off work for a couple of weeks, you're off work for 1 day. Yeah. So just incredible stuff. Yeah. So, and since something like 40% of women have fibroids by age 40, and the lifetime incidence in Asian, Hispanic, and Caucasian women is 70%, and women of African heritage, it's 80% likely they will develop fibroids in their lifetime. And people have studied this subject, and unfortunately, African American women end up having myomectomies, not hysterectomies, take the fibroids out at an average younger age than anyone else, and the age of hysterectomy is younger for African American women. So I see that, to me, the Sonata technology is a real important thing for the African American community, because this, instead of having surgeries and invasive procedures, I mean, we can just zap their fibroids. And it's just, I'm just so excited about this new technology.
Sonata, huh?
Yeah, Sonata. It's these researchers come up with catchy names. So instead of something like transuterine fibroid ablation, which would be TUFA, or some TURF, transuterine. It's just all sorts. So they come up with these names, but they take a letter here and a letter there, and they make it into whatever they want it to be. So, but it was kind of funny. And the next question they asked me was, how do you know if you have them? And you've already explained, that bleeding thing. Oh yeah, and I mean, I bet you there were days on your period when you got out of bed in the morning and it looked like a crime scene occurred. It looked like somebody murdered you in your bed last night. It's and I'm so glad you can laugh about it now. I'm sure at the time it was not funny.
Don't worry about it at all now.
Oh yeah, I feel for those ladies, and I can tell you one lady, she put a plastic like drop cloth on her bed, and then a bunch of towels on top of that, and I'm sure she didn't sleep well. Just how sad it is, and but the when they get bigger, they cause a mass effect. They cause your to have to go to the bathroom more frequently because they're pressing on your bladder. So people stop. The woman asks them when they're due, because usually if they get really big, they look pregnant. And then when they get that big, they can cause a lot of pain, and it's hard just to sit up to get out of bed some days because of the pain. So the simple classification for fibroids, there's the submucosal. Those are the ones that arise, close to the cavity. The interstitial fibroids, you're looking at this diagram. The interstitial fibroids are the ones. Oh, we can pull up the slides, I bet, can't we? We are so high tech, Joan. We've got slides. This is slide number 2, and it shows the fibroid classification. And so the submucosal fibroids, they're the ones that arise next to the cavity. Your uterus doesn't have to be very big, and they can cause the bleeding issues. And the thing about submucosal fibroids is, a lot of times a woman will go to the doctor and talk about how her periods are getting heavier, and doctor, nurse practitioner, PA does an exam, and doesn't really notice the uterus is real big. And I can tell you, I've seen so many patients that came in and they were frustrated because they didn't know why their bleeding was heavy. They were just told it was age. They said, I got to do something about it. And we do an ultrasound, and all of a sudden, boom, we have the answer. And it's because a small fibroid, a half-inch fibroid in the right location can cause a lot of grief, a lot of heavy bleeding, a lot of cramping. And those are the ones, those little ones on the inside, are the easiest ones to treat, because you go through the cervix, you take them out, and it's just so minimally painful. The interstitial fibroids are the ones that are the ones that I'm really excited about being able to treat for the Sonata procedure, because they start right kind of in the middle third of the uterine wall. So it's not until they get much larger that they start to cause problems like bleeding, and as they get larger, then they create that mass effect when the woman walks in with the enlarged uterus. And we normally talk about pregnancy sizes, but it's easier to understand the fruit scale, and I don't remember what your fruit scale was off the top of my head, but you probably had a couple of oranges and a grapefruit in there, or something to that effect. I mean, it's the watermelons that are the big challenge when they get really big. And just the other day, a gal walks in, and literally she was wearing her old maternity clothes, and she definitely looked pregnant. I mean, it was literally a watermelon-sized uterus inside. So, but the nice thing is I can offer her a laparoscopic approach even for that large of a uterus, just because been the good fortune of having great mentors and opportunities, and getting involved with the society many, many years ago to learn this. Now the subserosal ones, they're the ones that grow out of the uterus. They arise in the outer third of the muscle wall. And those are the ones usually don't cause a lot of bleeding, and they kind of like grow silently for a long time. And those are usually the ones where the woman walks in, she's got urinary frequency, or maybe she rolls over in bed one day and goes, what the heck is this? And feels her tummy, and all of a sudden she feels the mass. Or she's just in for a pap smear and everything's great, and they do the exam, and all of a sudden it's like, whoa, there's something going on. And so those are the ones that they got to generally get a lot bigger, and they kind of creep up on the woman generally because they don't cause a lot of bleeding problems. And again, 8, 9, 10 centimeter fibroids, 10 centimeters size of a newborn baby's head. We can take those out laparoscopically. We don't have to do a hysterectomy unless that's what the woman wants. And again, just thinking about what if I were in your shoes, and I'd sure want somebody to talk to me about all the options. And so many patients who don't want a hysterectomy, they keep searching for somebody who might help them. And if you don't want a hysterectomy, come to us. We'll offer you any other option. We will not try and force you into a procedure you don't want. So, they get big, they cause problems, and again, Dr. Walliser reported that we had a 98.5% successful laparoscopic rate. And this was in our first 200 and some cases. Now, since then, it's been over 99% success with laparoscopy for the fibroids for myomectomy. So Dr. Brown, who was the fourth fellow, she did a review of something like 800 and some hysterectomies, whereas Dr. Liu did the first 104. We'd done a lot more by the time Dr. Brown arrived, and she looked at those. Over 99.5% of our laparoscopic hysterectomies are done successful laparoscopically. You never know when you're going to run into a complication, and that's always the risk of surgery, but to be able to pretty much 99+% of the time be able to do it, it's just incredible how much quicker the woman returns to work. And a couple of weeks ago we were talking about one of my patients who came to see me because she was afraid she'd lose her house, lose her job. Didn't have a very nice boss. Wasn't very understanding. Was a guy. But she was, she was basically told, you can't take 6 weeks off work. You'll be, there won't be a place for you anymore. And I did her on Thursday, and she was back to work on Monday. And fortunately, the boss was nice enough to let her go home after 4 hours. But it's just incredible how quick the recovery is after these fibroid surgeries, and then to now be able to start offering something that's even less invasive is just so exciting. That was kind of the draw to uterine artery embolization for a lot of women back in the mid-90s because laparoscopic surgery was just starting to take off, and we didn't do our first laparoscopic myomectomy here in Denver until 1997. That's when we had the morcellator, and the morcellator allowed us to do it laparoscopically without having to expand that middle incision, and so we were just excited to be able to offer that. And it was interesting because that first myomectomy, she still comes to see me too, and so very nice lady, and so it was in February of 1997, and so that's kind of the fondness of why February is Fibroid Awareness Month. Not only that it starts with an F for fibroids, and I don't know that July would be a great month for fibroid awareness because, we have a question. Oh, thank you. And this is Monica. And thank you, Monica.
Monica asks, so is it normal for fibroids to be confused with endometriosis?
When they cause pain, definitely. Fibroids can cause pain when they expand. They can cause bleeding, but not every woman has bleeding, but not every woman has pain. But yeah, they can cause pain. And submucosal fibroids are notorious for causing an increase in flow and pain. And now anytime a woman comes in complaining of pain, we think of endometriosis, and then we start the workup. Now, ultrasound is a very important tool for diagnosis. And on the ultrasound, if we see fibroids, if they look like they're the explanation, we talk about that. But if we're going to do a laparoscopy to take out the fibroids, I always look for endometriosis and always treat it. The idea, you're going to be there once, you're going to be in there for surgery, not just doing one thing and one thing only. Oh, by the way, and I've had patients come tell me, they said, oh, by the way, here's the endometriosis. We see it, we treat it, we want to do everything we can to, give the best outcome possible for each and every patient. Fortunately, you didn't have any endometriosis.
No, thank God.
So yes, ultrasound is very important, Monica, and then you kind of know a little bit more. Now, something that's also a cause of pain is adenomyosis. And adenomyosis, adeno means glands, myo means muscle. It's glandular tissue that looks like the uterine lining inside the muscle of the uterus, whereas endometriosis is glandular tissue that looks like the uterine lining, only outside the uterus. And the tissue that's the uterine lining tissue is called the endometrium, and that's why it's called endometriosis. It's just a different doctor historically, centuries ago, described something different. And so adenomyosis is important to diagnose. I've seen more than one woman come to me being told she had fibroids because she had a big mass in her pelvis. But, the two other things that cause mass is ovarian cyst and adenomyosis. And so ultrasound is very, very important. I can remember a lady several years ago who came to me about her fibroids, and she'd been to 2 or 3 doctors. Nobody done an ultrasound.
Oh, wow.
And here we did an ultrasound. Her uterus was completely normal, but she had this big ovarian cyst. Well, that kind of starts to change things a little bit. But even with big ovarian cysts, we can do those cases laparoscopically as well. And again, the pain and recovery is a fraction. And having kept a database and having had a fellowship program and trained doctors, it's amazing how much can be done with the small incisions.
Amazing, for sure.
So the third question they asked me from Channel 9, thank you, Monica, is that, how do you prevent it? And honestly, there's no way to prevent it. Now, someday, some smart doctor is going to figure out a way to splice in a gene or do something as to how to prevent them. But early diagnosis is important. And, if you have an orange of a fibroid and, you go to the doctor, and again, a lot of times if we treat these as benign until proven otherwise. So we don't, immediately rush in and do surgery. But, when they're larger, I really think we should watch them more frequently, because as they grow, it's one thing when it goes from an orange to a grapefruit, that's still a pretty safe surgery. But when it becomes the watermelon, now you're looking at a much riskier surgery, much more risk of blood loss, needing a transfusion. And so there's a right time to intervene. And so, I see a lot of this in the community of, they said don't worry about it, but then they didn't come back for follow-up. Not necessarily because they weren't told to, but, sometimes it was just, see you next year. And it's important to know if a fibroid's growing fast or not, so that you can intervene at the right time when it's still safe and not more dangerous. And so, again, the Sonata procedure has so much appeal to, get these early when they're smaller with a much less invasive procedure. And so they do, ask me, and there are some online questions. So if you go to Channel 9 tomorrow, you'll probably see the online questions, which are very similar to the ones they're going to ask me on the air, really about treatment. And, really before 1980, all fibroid surgery was open. And I did, a fair number of open myomectomies in my, reproductive kind of fellowship here in Denver. And helped a lot of women get pregnant, and that was great. And then I started going to these society meetings, and people were talking about these things that they could do, and it was just fascinating. And the first time I ever saw laparoscopic myomectomy in a lecture was in 1987, and I was just fascinated by it. I thought, wow, this is totally cool. But it was really 10 more years before we actually did it here. And the early cases by these pioneers, some of them turned out not so well, because they were just starting to kind of figure this out. But by the time the technology caught up, we were starting to offer that. And the hysteroscopic myomectomy, I actually was able to offer that earlier, right around 1990. I started doing the hysteroscopic myomectomies, and they actually, I identified a patient. I had modified a urology resectoscope. Urology resectoscopes are for like prostate problems, and instead of having an end that's just open like that, they have this little hood that fits out over it to work in the prostate, but that won't work very well in the uterus. So I went down to the biomedical department and asked them if they would saw that off to make a circular end that was flat at the end, and started using that to do hysteroscopic surgery. And my first case was actually in 1989, using that modified scope for a woman who'd had multiple recurrent D&Cs from miscarriages in her cavity. Her uterine cavity was shrunk down to hardly anything from scar tissue, and I went in and used this little knife device that would allow me to reconstruct her uterine cavity to be the normal triangle it should be. She got pregnant like 2 months later. It was real exciting. And it wasn't long after that I'd been aware of these, and I identified a woman, and I'd already talked with the industry people, because they'd actually started making dedicated gynecologic hysteroscopes, and we'd been borrowing from the urologist to do those, but then we had the dedicated unit. And so for the first one, I called them up. I said, I have this, and of course the hospital was taking their time to buy it. So the company was very nice. They flew it in, and I did that, and that was in June of 1990. I mean, you remember these very first dates. That was the very first hysteroscopic myomectomy that I ever did, and really the first one ever done in Denver. So I'd had a little practice. I had about 20-some years of practice before you needed that procedure.
That's good to know.
Yeah, so it's just been a great ride, and when people talk to me about things they're doing, it just it's amazing. They're all excited, and I'm going, I don't burst their bubble, but when I look at some of these things, I was doing them 25 years ago. So it's just been a lot of fun to help women. And again, I'm really appreciative that you would come on and share your story with other women. And I think what you did a lot of is you said, I'm going to look for someone who can help me. So did you go on the internet? I mean, no, you went to a lecture. I'm sorry, that's right.
I think I saw a flyer for your lecture at Porter.
Yeah, so
that's somewhere I saw it.
So you were proactive. You educated yourself.
Yep. Yes, exactly. And we went through all the different treatment options, and that was helpful, very helpful. So what advice would you give to women who are just kind of finding out they have fibroids, or just kind of thinking something's wrong? Well, you might want to do a little bit of research online, but of course, it's not totally the best area to look for medical advice, but there's some good stuff out there. But eventually, I would suggest you see, a specialist for that issue, Dr. Moore, and find out, what's going on. Number one, and then, discuss with your doctor. Like a partnership, be open and discuss what you feel comfortable with and what you don't, and what type of treatment you feel comfortable with, and what's your path, to getting there. Like I took a little bit of time to get to the surgery, and that was okay. I don't regret that, but just view your health practitioner or your doctor as a partner, and in getting your treatment and getting some relief for your fibroids.
So educating yourself, taking a role in your own destiny.
Exactly.
Don't just trust the doctor. Now, a lot of women continue to go to their OBGYN after they deliver. And I mean, the doctor that delivers the baby is somebody important in their life. And yet, unfortunately, some doctors, they are very focused on their obstetrics, and that's very important.
Yeah.
They may not be as knowledgeable of some of these minimally invasive procedures. So, especially if the only thing that's offered is a hysterectomy. Anytime there's only a hysterectomy offered, that should be a big red flag to any patient that may be, especially if it's open hysterectomy. Because I've heard women tell me, yeah, it was the only thing that could be done. The doctor just acted like, that nobody else did them. And again, it's because the doctor some doctors are fully aware of it, they just don't tend to offer it sometimes. And there are very good doctors who do admit when they don't know something and they refer. And so, it's a lot of good doctors in our community, but some of them are a little reluctant to tell you that, you could have something way less invasive. Now, Janine says Monica has a question. Thank you, Monica.
Along those lines, I was diagnosed and given birth control for 6 months and given ibuprofen 800 milligrams for pain. And then the doctor told me the best case for me was to get pregnant, so everything bad would come out after the baby. Is this true?
Well, this is a historic issue with endometriosis, and I've seen many young women come to see me because after their laparoscopy they were told they had endometriosis, and the doctor said, if you don't have a baby now, you're never going to have one. And that led a few of them to having a baby in a relationship they probably never should have. In today's world, with our advances in medication, the philosophy's changed. It is possible to treat endometriosis medically and try to avoid surgery and put those things off until it's the right time. Yes, birth control pills can help, ibuprofen can help, but when those don't help, there are other things that we can do. And again, just like with Joan, I will sit down with any woman having a problem and treat them like my friend, my family. I want them to know what their options are because it's their body. It's not my choice. It's their body. They need to understand, and I want to make sure they understand it. And what is important to me is keeping in mind their beliefs, their philosophies, and working with them because, square pegs don't go in round holes and vice versa, and not every woman needs a hysterectomy or wants a hysterectomy. And again, one of the things that we can do to help women with endometriosis and fibroids, especially when they're kind of getting to that point where, surgery might be necessary, but that costs a pretty penny. We offer clinical trials here, and that allows women to get access to medications that, are in the process of achieving FDA approval. And we don't do like first phase 1 studies that, are really potentially dangerous. We do what are called phase 2 and 3 clinical trials where the safety of the medication has been established, and the company is trying to satisfy the requirements of proving that safety and effectiveness by expanding the number of women treated to several hundred. And so a woman who would love to get medical treatment and avoid surgery, if she doesn't mind keeping a diary of her pain or her bleeding, and there are certain requirements that are put in place by the FDA, but you can get this medication, and it can stop your periods, it can stop your pain for, in some cases, a year, and even in some studies, a couple of years. Now, you always got to be prepared to have a placebo, and because they have to know that it's working better than nothing. So we never know who's getting what. Now, I think we can kind of figure it out. 2 women are telling us one's period stopped, had 3 months ago. They're having a great day because they're not in pain. The other lady, she's still having periods, she's still having pain. But the one nice thing is generally after 6 months in most studies, the woman is allowed to get the real medication. And I try and look for studies where the placebo arm is as small as it is reasonable to get it, so that as few patients as possible have to put up with it. And then we love those studies when you could be on medication for like 2 years. That gives a woman time, time to plan. And so we can offer women a wide range of options to help them. Dead air, silence. So we had a couple of questions before, and one of them was about, are there any organic or naturopathic cures for fibroids? And this was from last week, and there really aren't that I'm aware of. I constantly look for studies to improve my knowledge base on fibroid care, endometriosis care, and I know there are people who offer herbal and naturopathic cures, and I'm not saying I know all of that. It's just if it works, great. I just always look for scientific data. I always look for that control group to say that compared to placebo, how did this really work? I like to do scientific analyses. But sometimes if it seems like it helps your symptoms, but eventually I'm worried these things will fail. But if I can get a fibroid that big, it's a lot safer than when they get that big. So that would be my biggest encouragement is to try and get in and get seen and get followed, so that as time goes by, we try the conservative things to keep you out of the operating room, but instead of letting it get to be a real tough surgery. I mean, on the 1 to 10 scale of surgeries, you really want to be the 1 or 2 or 3. You don't want to be the 9 or 10 of this is the worst surgery I ever did. So
I'd like to ask Joan a question.
Oh, okay.
Did you ever try any natural organic stuff when you had?
I was thinking back about that, and I don't think I did. Or if I did, it was more for just pain management, or like I lived on ibuprofen. That's not really natural, but I mean, I just remember living on that and taking so many of them. But I don't recall taking any natural supplements.
And a lot of ibuprofen can be tough on both the GI tract and the kidneys.
Yeah.
And we have seen those ladies where literally they had taken so much, their doctor said, you can't ever take any more again, or your kidneys will fail. Or your GI system, you're going to end up in the hospital with a bleeding ulcer, and have part of your intestine resected or something like that. So, and then I see a lot of women in their 30s with a lot of fibroids, and they go to an OB/GYN or even somebody who, if you've never had a baby, and I always look, because if a woman's never had a baby, I always in general have kind of had the impression that woman may not be ready for a hysterectomy, even if she's 49. And I can tell you of one story of a patient I saw where she had been to her family doctor, and she had, this was kind of one of those, she really wasn't aware of her uterus because she really wasn't having a lot of bleeding. But boy, the doctor's eyes got real big and said, you've got a problem here, and sent her upstairs, and they did an ultrasound. They found she had fibroids, and young OB/GYN was starting to tell her how a vertical incision could be done, and she could do a hysterectomy. Now, very intelligent woman, has more degrees than I do. We're talking fellowships at like Harvard and Princeton, kind of, those kinds of educations. And she said, this doesn't feel right. And she came to see me because she had found out, I did hysterectomies on big uteruses. And we had this discussion, and just like with you, I told her we could do a myomectomy or a hysterectomy. And it was very important because she called back a few days later and said, yeah, I really don't want a hysterectomy. And we took out a whole bunch of fibroids, and she's very happy today. And that was just important to her, that she would have settled for a hysterectomy because if it had been minimally invasive. I don't know that she would have done an open myomectomy, but when she found out she could have a laparoscopic myomectomy, that just had more appeal to her. and I think it's like that commercial, have it your way.
Mm-hmm. Yeah.
So and I'm very glad that you were able to have it your way.
Yeah.
And that not only that, but when they did recur, and that's the problem. Most 50% of women have new fibroids in 5 years. So it wasn't a surprise, and it was just as it got there, we were able to take care of it with an even less invasive approach. And that was the benefit of just staying with us, where we were able to get at that right time, so it was less invasive, less painful, and again, Janine just kind of flashed us that we're about to take a break.
Okay.
And we don't have any commercials, we don't have any sponsors, we're just here to do it. But Joan, thank you so much
Thank
for
you.
taking the time out of your
Thank you
day
very much.
to come and share your story
Happy
with
to.
the rest of the world.
Okay. Thank you.
You're welcome.